What I'd like to do to be able to give you and share with you the results of my collaborations with computer engineers. I believe, like probably most of you, that multidisciplinary approaches are key. And these are the ones I think that solve real-world problems where you put heads together from different disciplines. I'm a hematopathologist. I'm subspecialized in leukemias and lymphomas. And I saw some issues in pathology that could be addressed by technology that's associated with the skills that the computer scientists do. And I'd like to share with you one of these results. I hope to be able to share with you the virtual flow cytometry and hematometrics could be an application in digital pathology. As you know, this is a big player in the field of pathology where you convert the slides into digital scope, and you can magnify and see all the images within a single slide and transmit it in the internet and share it. And I hope this technology will be an application for that. It could also be a standalone app as a software in a lab, an office, with a computer, a microscope, and a digital camera. And I hope this technology will transform traditional pathology, you know, the look and see and estimating, visualizing, eyeballing, into a more objective pathology where data and computations are used. It's a little bit more involved than connecting dots like what this doc is doing, but it's basically boils down to that. So let's tee up by looking at some microscopic images. Some of these images are used in daily pathology practice for diagnosis. I will describe these images later, but for now, ask this question: can these images become data instead of just pictures? Can we go beyond eye visualization or estimates? And right now, we estimate them and put the estimate in the report, believe it or not, I guess for want of a better tool. But there must be a better way. There must be a way to go beyond estimate. The industry actually provided some answers to this. The biomedical approach was to quantitate antigens in breast cancer, and that's been successful over the decades, and we use that for prognosis and diagnosis as well. But that's not enough. We need to go beyond breast cancer antigens and extend it to all facets of images that we see in pathology or even research. Let's step back for a second and look at the bigger picture of how we put this technology in context. The well-known futurist speaker, Patrick Dixon, said, and on point, that computer-aided clinical decisions could be useful if it's safer, more precise, but less so in terms of getting less lawsuits from it, but more so in getting the patient's trust. So right now, the patient sees the report, and mind you, even with HIPAA privacy rules, they should. That's their report, after all. They're entitled to it. But what they see is somewhat embarrassing. It's based on estimates in most of the reports. It's not based on a lot of data, especially in anatomic pathology. I would take exception in clinical pathology, where most are automated, and you have data to support diagnosis. So can we do better? Can we go beyond estimates? And we can, and hopefully this technology can help us with that. So the bioengineering issue here, I think, is how do you reduce estimates? How do you convert pictures into data? In other words, how do you achieve good segmentation? And segmentation is one where you can separate the objects into non-objects and objects, and based according to the requirement of the user. So a good segmentation typically is one that satisfies the user requirements, fits the model for wide generalization, fast implementation, and applicability. In this case, as a pathologist, it should fit my workflow. No, we have hundreds of slides we have to work through every day. It should not interfere with my workflow. It has to be fast. The cycle time should be in seconds. It should not be in a separate part of the lab where I have to get another technologist to help me. It has to be right there and then to help me. And I think what I'm going to share with you would fit that requirement. It should be able to adapt to the heterogeneity of images that we see using a common thread from these images. And I premise that there is, no matter how different. And it should be obviously a multidisciplinary. I was not trained in computer science at all, but in medicine and pathology. So I need the help of you guys. So the premise is there is a common thread in data, and the color images in pathology are usually composed of 3 channels of red, blue, and green. And we premise that all information from the objects could be obtained from this. And that if you transform the RGB into their components, hue, saturation, and brightness, that likewise information could be obtained from those, separating objects from non-objects. And that the combination of the above channel allow application in a wide variety of tissue using different stain, using a standard segmentation bioengineering tools in a defined sequence. So there are many issues in surmounting this problem, and one of the bigger ones is the variability of the staining. Because day in, day out, the chromogen that we use may be darkly stained or lightly stained. And one way to look at this is if you separate and split the dark stain images into its components. This is a dark, highly magnified area of a positive cell, lightly stained cell, into hue, saturation, intensity. You could see that the saturation is invariant. In contrast, the hue is invariant. In contrast, the saturation and intensity varies. Likewise, if you magnify a hematoxylin-stained, counter-stained, negative cells into its pixel components and compare that with the brown positive cells, the hue is separable from each other, indicating maybe this is one way we could separate them. So we created a workshop paradigm in which not unlike a workshop that you see in a garage, you have a set of tools, the best tools you can get. You start with a raw object, let's say a piece of wood to create a furniture, and you apply this in a defined sequence. Only one sequence that will create one product. In this case, an example would be your best wood, Honduras mahogany, to your heirloom Queen Anne table, for example. In our case, any kind of beginning image in pathology would generate the final product. We premise this strategy using a pipeline of primitive, familiar, but reliable segmentation tools that could threshold and partition objects using the workshop model. We use a limited set, thresholding histogram by Riddler and Calvert intermeans, the Kapoor maximum entropy, the grayscale mask, the watershed of Vincent, the Voronoi and Dirichlet tessellations, the ultimate central points or centroids, mathematical morphology, and image math. We believe this will lead to robust apps in any number of pictures, whether it's a bone marrow, a stroma, or any biomarker, and will handle both bright field as well as fluorescent images. So let's come back to the images that we showed you earlier and describe them more in detail. We believe this technology, which we call hemanometrics, because it's applied to areas in my field, in lymphoma and leukemia diagnosis, but it could be oncometrics, it could be solid tumor, it could be any application that requires metrics. The first image is a biomarker for T suppressor CD8, and the positive cells are those brown stained cells, as you can see, and the negative ones are the counter-stained blue cells in the background. And the object is to be able to get the positive and the negative, get the total cells, and get the percent. And this would be useful in a lot of things, diagnosis of lymphoma, getting ratios, CD4, CD8, for example. And this would be an archetype. This could be a different antibody to, let's say, B cell or T cell or any lineage-associated antibody and get that information. The second image is pan-keratin. That's a marker that's composed of at least 3 components, AE1, AE3, and CAM5.2 as a cocktail. And it's useful to detect a metastatic disease. You want to be able to say, if the morphology is not very clear, that this is a carcinoma, that this is not a lymphoma, which should be negative for keratin, that this is not a sarcoma, and this is not a melanoma. And so pan-keratin is used to answer that question. In addition, this stain would be able to give you the tumor burden. Nowadays, if you do sequencing and molecular genomics, Sanger or next generation, you need at least 20% of the tumor to be there or more to be able to get a valid result. And this would be one application. The third archetype image is a tumor-infiltrating lymphocyte. The tumor, in this case, is a breast. It could be a small cell, non-small cell, colonic, head and neck carcinoma. And the question being asked is how much tumor-infiltrating lymphocytes there are. And again, any marker could be applied to this. It could be PD-1, a checkpoint marker for immunity. It could be CD8, CD4, CD20. Depending on what the user requires. At the bottom is a confocal immunofluorescent image of a tumor stroma in which the cytoplasm and the membrane has been stained with fluorescein. And the intracellular marker has been stained with a different marker, let's say for tumor oncogenes or tumor suppressor genes. By the different color stain. And the objective is ask the question how many cells there are and how many within each cell the biomarkers are there. This image here is a reticulin stain. Probably many of you are familiar with this. This could be applied to bone marrow, as in this case, but could also be applied to liver. The higher the fibrosis in the liver, the closest it is to cirrhosis, and the higher the stage, the worse the prognosis. Similarly, in the bone marrow, this is a type of chronic leukemia called essential thrombocytosis, in which the abnormal cell are the megakaryocytes, as you can see here. We're not after that. We're after the reticulin. So the objective of the segmentation is to remove those cells as non-objects and retain the reticulin as the object. And normally we grade them from 1 to 4. And the higher the grade, the worse the prognosis. The last image is a bone marrow. It's a tissue biopsy of a bone marrow, and bone marrow is very useful. When you have a patient with anemia, leukemia, if they're in the bone marrow, it's stage 4. Bone marrow cellularity is a way to determine if the cellularity is normal for age. It's inversely proportional to age. If you're 80 years old, your cellularity normally is 20%. If you're 20, your cellularity is 80%. So we need an accurate bone marrow cellularity. Right now, we estimate them. And the variability is pretty high, as you can imagine, between pathologies and within pathologies. So let's look at the first image. The first image is a CD8 with counterstained hematoxylin. And as I said, the strategy is to first start at the end. You want to be able to ask the question, which one are you after? You want the positive cells and the negative cells, and therefore, the sequence of analysis should be towards that. So the first sequence would be thresholding the red channel and the blue channel to generate A and B, to combine that to generate a C preliminary image, threshold the C using the hue to get a preliminary image called D, combine the C with a D to get an E, threshold the brightness channel on E to get an F, or the D with an F to get a mask of a G, which represents similar to the positive cells. Meanwhile, you threshold the blue channel within C to generate the H mask, and you end the H and G and XOR the H and G to generate the positive and the negative mask, which are now cell-connected and labeled, which is now amenable to data analysis to be converted to the result of the total positive cells, the total cells, the negative cells, the staining intensity in the y-axis, in the x-axis, excuse me, and the cell size in the y-axis. Effectively saying this image now is data. Let's take the second image, which is an archetype of tumor-infiltrating lymphocytes. And in this case, it could be PD-1, a marker for checkpoint that could be blocked by targeted antigens to minimize the tumor suppressing the immune response, for example. And we want to ask the question how many positive cells there are. This is a more difficult issue because where you are and where I'm at, it's difficult to see the positive and negative cells, but they're there. Again, we use a similar strategy. The object is to remove the carcinoma cells, and the final object would be the positive and the negative, and the data therein that could be used for analysis. Here is the pan-keratin stain for, let's say, metastatic carcinoma. The objective is to determine the total carcinoma and remove the extraneous stroma or lymphocytes surrounding it to generate a positive percentage result as well. And here's bone marrow cellularity, in which the final object is getting the percentage of the bone marrow, which now I could tell if this patient is let's say, 25 years old. This is severely hypocellular for age. And therefore, there is something abnormal going on. And if the blood has a lot of cytopenias, then this could explain the problem, that your bone marrow is failing, and this patient may be developing aplastic anemia, for example. That's one application. Similarly, if this cellularity is pretty high for 25 years old, let's say 80%, well, patient might have another disease called chronic myelogenous leukemia, which can happen at a young age, which could be then worked up. There is now a targeted biomarker for that, the Gleevec or imatinib, which will cure that patient. So that's a very important data. Here is the reticulin stain on a patient with essential thrombocytosis, one of the subtypes of a chronic myeloproliferative disorder. Again, the object is to be able to separate the megakaryocytes, which are dysplastic and abnormal, from the reticulin. And here you come up with the highest grade 4+, based on the algorithm, based on the way it's constructed. Here is somewhat more familiar to people doing research in confocal and immunofluorescence, where you ask the question how many cells there are, how many biomarked population there are inside the cell, and you come up with a 2-cell population with the target molecules comprising 14% inside. And I'm pretty sure this could be useful in a lot of applications. We looked at the tissue microarray. As you're familiar with tissue microarray, you do a few punts and array this in a slide. And it could be different tissue, same antibody, or different antibody, same tissue. In this case, different antibody, same tissue, which are different kinds of lymphoma, analyzed. And these are the virtual flow histogram result of the positive and negative cells, indicating a dual Gaussian population of the positive and negative cells with good staining separation. How does it stack up if we look at the tissue cytometry data? The precision recall statistic is pretty high, about 90%. The staining accuracy is near perfect. The algorithm can separate positive and negative well. The segmentation accuracy about 92%, the area under the curve. If we compare it with flow cytometry, the standard technique in our practice, then it also has high correlation of 96%, indicating this could be a surrogate if your tissue did not come fresh, because flow cytometry requires fresh tissue, and therefore you'll be able to analyze it using fixed tissue on a slide using virtual flow cytometry. Here is the correlation between the manual grading of the pathologist and the computer result, with high correlation, close to 98% as well, excuse me, with good 95% significance. This is the correlation between manual reticulin stain estimation of the pathologies with the computer. Now, the estimation could be converted to a more objective, repeatable result. So in this limited example, data could be obtained, and you can still ask the question, is this a better way than eye visualization and estimating metrics in everyday pathology? I guess we'll go back several years and look at a result been published from computer-aided breast cancer antigen analysis using a different machine that's standard now in our practice, called ACES or Chromovision, or there are many permutations of them, from Aperio, from Ventana, etc. And this study actually highlights, if you give the 10 pathologists the same slides, stained the same way, and ask them to grade the same type of tissue and grade them from 1 to 4, without computer aid, you have an analysis that's all over the map. If you use computer-aided analysis, the agreement is higher with an ROC that is higher. And granted, these pathologists may be a different mixed bag. Some are novices and some are more expert. But you're given the same slide, and if the pathologists can reproduce their data, you should be able to get a high result. But it probably is not the fault of the pathologist per se, and this I echo what others have said. But maybe we're just not good, not good in converting the algorithmic range of this staining. Let's say this is the figure of the DAB range from 0 to 1,000 plus, which is logarithmic, to a linear scale. And even though this looks linear, from the beginning to the end, it's actually a logarithmic range of staining. In addition, the human eye is just limited to resolution, to the perception of intensity, unlike a computer. And we cannot separate hue away from its other component in the background. For example, this pink here is identical to the pink on this side, yet we are fooled with the surrounding green, which is closer compared to this other one. And we also perceive false contours, and we have illusions. And this may figure in the way we look at things. So let's shift gears and ask the question, how does virtual flow then compare with the standards in the clinical practice now? This is a machine where you send the breast cancer antigens and quantitate HER2/neu, estrogen, progesterone. And this machine and many other machines similar are actually based on antigen density using color ratio per pixel of cells. In contrast, virtual flow cytometry is more suited to cell events like flow cytometry, with a ratio based on single cells or intercellular biomarkers. The examples I show you here is a patient with a bone marrow who's been treated for myeloma, and the clinician is asking the question, how much post-therapy is the residual myeloma cells? In this case, the myeloma cells is stained with CD138. So that's one question. The other question is, there are other brown stuff in the background that I don't want you to be able to segment. So they stain it with red because the hemosiderin, which is part of the reaction of the tissue to the chemotherapy, is there. And so virtual flow is able to select only the red and discount the brown and come up with the data. This is another company that use the same image that I have on the screen right here, and come up with a percent cellularity based on the total area, which is 21%. In contrast, virtual flow had 26% positive results over all the single cells, compared to about 21% of the single cell analysis. Here is another company that analyzed Hodgkin lymphoma cells, whereas virtual flow separates the individual Hodgkin lymphomas, shown here in brown. The other company do pixel and area analysis, which I think is not as accurate. So let me let me show you the typical applications of virtual flow. The motivation that started virtual flow was many, many years ago when I had this problem. I was asked how many lymphocytes are there that are positive, and all I could do at the time was draw grids and count them individually. As you could imagine, that's quite difficult. And some people call me, I have 1,000 slides. How can you do it more effectively? And the answer is a no-brainer. You need a computer to do that. I want to show you that cytology preparation is different from tissue. It's not so obvious, but when you do a cytology imprint of a tumor cells, you imprint the whole cells. So the boundary issue is very important. You need boundary information. In virtual flow, it's analyzing tissues, so the tissues are actually cell objects. They're part of the cells because the thickness of the microtome, here's the microtome cutting the tissue, shown here diagrammatically, is about 5 microns. And the cells in this case, the lymphocytes, are 8 to 32 microns. You could imagine equatorial, polar segmentation. You have all kinds of cells shown here in bas relief in different sizes and shapes. So these are not really cells. These are cell objects like flow cytometry does. These are events, if you will. So boundary segmentation is not the answer, but some other technique. I hope that the virtual flow could be an app to whole slide imaging, which is digital pathology, which now database networks share and store, and the whole slide imaging is available in many, many centers now. But it probably needs a virtual flow to enhance quantitation as well, because this is not a well-developed area. Whole slide imaging is yet to be approved by the FDA, but it soon will be approved because there is need for telepathology to have consultation in resource-poor countries to people who are better off. And there are applications for that as well. And the app, as you can see, is very similar to our smartphone paradigm. So the way we do traditional pathologies, we look at a carcinoma, we give them positive or negative, and the permutation of the positive negative tell us what kind of tumor it is. So it doesn't give us the exact percentage of tumor burden. One application of virtual flow is to conduct this analysis, give you the result, the data, which could be used, let's say, for BRAF or KRAS DNA sequencing, which requires a certain percentage for results to be valid, whether it's Sanger or next-generation sequencing. So how does virtual flow differ from flow cytometry? We call it virtual flow cytometry because it is predicated on ability to be able to count cell objects. Just like a flow cytometry shown here, you count individual events, cell objects, count the positive and negative, and give a percentage. Unlike flow cytometry, the virtual flow can work with fixed tissue on a slide, convert this to individual elements, and give you data. Flow cytometry requires disaggregated cell suspension, live cells, like blood, bone marrow, biopsy, disaggregated, separate individual cells, and run through this machine to get the results, which is a standard part of practice. So for example, this result, CD20 is a B-cell marker in normal lymphocytes. When it is co-expressed with some T-cell marker like CD5, that's abnormal. And this is quite characteristic of chronic lymphocytic leukemia, for example. Another difference is that the virtual flow is a direct view of the tissue. Flow cytometry is not perfect. Large cells and cells could die in the macerating process, and you would lose important elements, and they may not be representative. So pathologists often correlate the result of the flow with the tissue and look at the slide anyway to be able to do the validation for the result of the flow. So we described this technology in cytometry a while back in collaborations with some other pathologists and with computer engineers and their companies. And we applied the process and prosecuted this as a patent without any attorney, and luckily got a patent awarded to us. We applied it recently in molecular pathology of the thymus. And I would like to make it clear that it's different from the prevailing machines now in the market, which quantitate antigens. We are not in that business, so to speak. But we'd like to target the laboratory that be able, or even research labs that be able to convert images into diagnostic data or metrics. And I would say that this software would work with any combination of microscope, any CCD camera, and a computer interface. So what I've shown you is there is a better way than just estimating these metrics, and that virtual flow does true counting of the total positive and negative cells to give a dual population, which is next generation above area analysis, and that virtual flow extend to hematometrics or oncology metrics using this paradigm, and it should be applicable custom-wise to any result that the user requires, and that it may push traditional pathology into computational pathology, which I think, at least I believe, and probably you believe too, that this is more in line with precision medicine and genomics. And here is a brochure from my company where we apply this technology as part of the pathology solution. We also customize the user requirement. I used to be a director of fellowship in hematopathology at Moffitt Cancer Center, and for that, I generated a couple of textbooks to help young doctors learn this skill in morphology, which I believe was disappearing. And the result was teaching them the basic and cutaneous lymphomas and leukemias, and separating benign lymph node from malignant as well as infectious lymph node. And I thank you for your attention, and I will entertain any questions now. Thank you.
That's very interesting. Can you, what is the penetration depth of the dye into the actual sample?
The dye. Okay, the dye is the standard hematoxylin eosin, and it's a bright field, and so you use a regular microscope and regular biomarker, like an immunohistochemistry. So the dye is on the surface, I guess. It's a 5 micron thickness tissue, as therefore there is no issue as far as the depth. But I guess the question you're asking is, can you actually imagine deeper if you have a thicker tissue?
What I was kind of going after is whether or not you can focus.
Yes.
You know, it doesn't take much
Yes.
to be able to get an idea of what the real morphology is.
Right.
Not just
Understand. I understand. That issue is not my issue. That issue is more related to the issue of your machine that be able to extract that. And any technology at all, like what you use in the practice that can image that depth, will be able to generate an image, and this image will be used in virtual flow.
That's why I was asking this. Image at slightly different levels you can get, even though it's a very thin sample, you can still have some idea of what, you get a little more information.
Yes, on the z-axis, yes. Yes, so it's applicable as well. If you move the z-axis from Z1 to Z whatever, and get the image from that, you extract the same different set of sequence of image, and you can analyze each individual image as well as the Z1 to Zn. So it really doesn't matter. You just have to have a machine that will be able to extract the z-axis from each one, which is a confocal technology, not the usual wide field, bright field that we use. Thank you. Good question.
Any other questions? So when you use the computer automatically to help you to analyze all those images, do you have some idea what exactly the kind of the error rate computer may generate?
Yeah, I showed you earlier. It's about the segmentation accuracy is pretty high, about 92%, and the staining separation is virtually perfect. The correlation as far as with the pathologist is close to 100%, 97, 98%. And when we correlate that analysis with another technology, the flow cytometry, the correlation is pretty high as well, about
Okay.
98%.
Okay.
So it's comparable to the standards of practice. And I think we could live with that because we're not all perfect. So machines probably are not as well.
Okay.
This basically just takes away the human error.
Yes. That, you know, your diagnosis at 8 o'clock in the morning on the same tissue and you forgot about it, if you can, will be different at 5 o'clock when you're tired. And that's just the way human is. We get tired and we have all these foibles, if you will. Thank you for your questions.